All right, so I'm just going to do a really brief introduction here to two recordings that I've made in the past because I think that the recordings for this week are actually still pretty relevant. But it is a little rough because I pulled it from two separate recordings. So I just wanted to preface the videos with a statement. So I jump into first a brief overview of another article on essentially adherence or adherence variables. Um, because for your final paper, you have to create an individual intervention, and then you also have to consider how the potential for that individual intervention to function on a public health scale. So how do you bring that to scale? And so I think adherence is an important piece for each of those. So I wanted to introduce that paper still, even though we didn't read it this semester. Uh, there is, if you're following along on the slides as well, there's an additional summary slide that I think is helpful. It's a summary slide for the adherence article, and then there's also an additional slide on the REAIM framework, which just frames each aspect of REAIM as a question. So I just think it would be helpful for you to look at the PowerPoint slides independent of the lecture presentation. In the presentation, I did want to say, so in the second video, I say that phase 2 and phase 3 trials aren't humans yet. Um, that's sort of wrong, at least when I was re-listening. I was like, so phase 2 and phase 3 trials are in humans, but it's typically preclinical data, meaning whatever's being tested hasn't been brought to clinical practice yet. So, for example, right now there is retatrutide. So we have semaglutides, we have tirzepatides, and then we have retatrutides, and you should be familiar with those three things because we talked about them in our body composition lecture. Uh, Semaglutides and tirzepatides have gone through phase 2 and phase 3 clinical trials, and they're used in clinical practice, right? They have FDA approval. Retatrutides have not. Retatrutides are in, I think, phase 3 clinical trials right now. So I would expect them to be on the market at some point soon, but they're not yet. We are studying disease in humans. It's just not used yet in clinical practice and certainly not in community-based interventions yet. I do mention in that video paper on body composition that we didn't read this semester. Don't worry about it. It's not necessary for your understanding. I just mentioned mediators and moderators a little bit, which we've talked about several times in the last couple of weeks. So I think you should be good to go in terms of understanding. Just a quick overview, right? Mediators are on the causal pathway, whereas moderators are not. They're affecting the strength and direction of the relationship between my exposure and my outcome variable. So they're answering questions like, for whom does this matter and under what conditions does this matter? And then just as a way to make it even tougher to organize your thoughts. Then you have things like confounders that are affecting both the exposure and the outcome, but they're not necessarily on the causal pathway. So oftentimes things that are considered confounders are things like education, age, or socioeconomic status. Okay. And I will say that sometimes sex or gender can be used as a moderator or a confounder variable. So it just depends on sort of what the research question is. All right, with that, I'm going to let you jump into our first video. I wanted to introduce one other paper that I think will be beneficial for your final. But before I do that, I want you to answer this question, and it could be for yourself, could be for somebody else, but what are key things that you feel like make you or people in general more likely to engage in physical activity? Just take like 30 seconds, a minute, 2 minutes, jot some things down. What do you think associates with higher levels of physical activity? I'm going to pause here for a minute and just give you some time. Okay. So I hope you've come up with at least a couple of things. Feel free to pause the video and keep sort of jotting some things down. One thing that I hope you've learned through this class is that there are answers to your questions. There's an answer to this question. But in order to really absorb learning, it's often helpful for us to predict things and then find out what the actual answers are. So that's why I often will do this. I'll ask you a question and then I'll present evidence that sort of tries to answer that question. So this is from a Tross et al. 2002 paper. It's a little bit old. I should update this at some point, but this is, I think it's a really simple figure to interpret, and I'll walk you through it. The citation for this paper is in the PowerPoint notes. So if you would like to use this for your final, you can go in and cite this. So this is looking at a determinant of adherence to physical activity. So what makes people likely to engage in and maintain physical activity? So looking at demographic variables, sorry, let me get my laser pointer. So we're looking at demographic variables, psychological variables, behavioral attributes and skills, and then this list continues on to the next two slides. What they did was they compared a meta-analysis to sort of an updated review. And the double negative means there's a strong negative association between this variable, so age, and adherence. And this is an older review. So in the older reviews, there was a strong negative association here. In the updated review, also a strong negative association because you see that double negative. Okay. In if you're in a blue collar occupation, okay, so maybe more of a physically demanding job, you are also less likely to engage in and adhere to a physical activity program. The evidence isn't quite as strong there, so that's why you only see that one negative. Now we go down to childless. If you are childless, you are more likely to engage in and adhere to an exercise program. Again, not super strong evidence, but positive association there. And then this graph goes really nicely in order for us. We have gender. If you are male, you are more likely to engage in and maintain adherence to a physical activity program. Okay. And then these citations are all of the papers that support that assumption. So it makes sense that this has a single negative and a single positive because there's only two papers supporting those associations. Okay. So demographic variables are, generally speaking, things that you can't change or that are relatively stable. Okay, so race isn't going to change. Overweight and obesity, that status could change, but ultimately is relatively stable usually. Okay, so if I'm overweight and obese, the old review said there was no association. The new review says there is in fact a strong negative association with being overweight and obese and your likelihood of maintaining or adhering to a physical activity program. Okay, so I'd like you to take a look at the next three slides and sort of go through and see, okay, well, were you correct or incorrect? Did you guess correctly the positive things associated with physical activity adherence or not? And what things sort of surprise you? Okay, I would highly consider you do this. Obviously, this is online, so you don't have to. Okay, but there are three sections here. So we ended at behavioral attributes. Okay, there's a social and cultural factors. There's physical environment factors. There's also physical activity characteristics. So if it's highly intense, less adherence. If perceived effort is high, less adherence. Okay, so in any case, go through, look at these, see what it is, because this will also come in very handy in your final. Okay, this is another great paper looking at predictors and barriers to physical activity adherence. So you can see these are adjusted odds ratios for barriers, enjoyment, and preferences as predictors of the likelihood of engaging in these activities. So I'm going to walk you through this figure so that you can do it for yourself on the next slide. But so these are predictors. So physical activity barriers. So if I listed cost as a barrier to physical activity, so as an individual, I said cost is an issue for me. If I say cost is an issue, then there is a significant association between those individuals and their likelihood for engaging in walking. And those individuals are more likely to engage in walking. So remember, an odds ratio greater than 1 indicates that they are more likely to engage in walking. They're also more likely to engage in moderate physical activity and less likely to engage in vigorous physical activity. And note the p-values, those are all significant associations. Okay. Now, if we look at work, so if I listed work as a barrier to physical activity, I'm less likely to engage in walking, moderate physical activity, and vigorous physical activity. Again, all significant associations because you see those p-values less than 0.05. I want to come down to if you prefer moderate physical activity, you're more likely to engage in walking and moderate physical activity and less likely to engage in vigorous physical activity. Okay, that's that odds ratio below 1. Okay, notice though that was not statistically significant. Okay, so yes, you are less likely, but in a non-significant way. Okay, so make sure you pay attention to those p-values, especially on your final if you're going to reference a paper like this, right? If the p-value is non-significant, then I can't say with confidence that someone who prefers moderate physical activity is less likely to engage in vigorous physical activity because I don't have confidence in this odds ratio. Okay. Okay. I'm going to let you puzzle through that. Again, if you have questions, please come talk to me. This is another great one. So, sorry, looking at sedentary behaviors. So I asked you to look at physical activity and sedentary behaviors. For sedentary behaviors, TV viewing, right? Reading, social activities, and then just total sedentary time. Okay, and how these associate with barriers to physical activity, enjoyment of physical activity, and preference for vigorous physical activity. Okay, so again, really some interesting findings in here, and I'm going to let you sort of puzzle through those. Okay, so this week we have Dr. Estabrooks coming in, Paul Estabrooks, to talk about public health and translational research. So I'm going to try to give us a little bit of a background before we jump into that. So translational research, first and foremost, the idea is that you're converting basic research findings into usable strategies to improve human health. Okay. Um, Basic research is sort of when we're looking in this first, let me get my laser pointer out for us, in this first set. So this would be sort of my basic research. I'm looking at cells, maybe animal models, tissues, biochemistry. And I could even lean into this diseases portion a little bit in the basic science world. So that's basic science. So it's before we really applied it to humans at all. We're just trying to discover sort of mechanisms here. Uh, but the end goal is to sort of get to here. So to change policy to help individuals and communities improve their health. One of the Well, no, before we get there, this would be sort of termed the linear pipeline. So this is the basic idea behind translational research. So we'll get into some of the messiness in a minute, but the basic idea is, yeah, we start here with cells, then we look at how those basic findings. So in this case, let's just take insulin, for example. So we might look at skeletal muscle cells and introduce insulin to the skeletal muscle cells and see what happens, what's their reaction to that. Then, when we're examining diseases, we might look at, okay, if I have chronic exposure to insulin, now does the response of the cells change? So we've talked about insulin resistance. You should all be familiar with that principle, right? And we know that it does indeed change, which is a disease, right? We have type 2 diabetes there. When we have sustained insulin resistance over time, then we see reduced pancreatic function and eventually pancreatic failure, and you have now a reliance on insulin in order to utilize glucose appropriately. Okay. I will say I want to stop the process just for a half second here and talk about how there are health outcomes outside of disease. And I've tried to emphasize that in this second half of the semester that, we often look at cardiovascular disease, diabetes, cancer, obesity, these chronic diseases that are causing lots of issues. But there are also other things to examine, like quality of life and cognitive function and subjective well-being. So we're not, and even mental health, which yes, we can get into some diseases there, but I just want to emphasize that there are ways to do research and ways to engage in public health interventions without necessarily focusing on disease. And I do think a focus on disease is important, but I just want to highlight that it doesn't always have to be disease here. So this was from a 2014 paper, and I just would characterize it a little bit differently. It's also helpful for some of you to know, like when people say phase 2 or phase 3 trials, we have not made it to people yet. Okay, so phase 4 trials, we've now made it to people. Okay, will it work? Is it worth it? Right? That's where we start to see some like cost analyses, etc. So cost effectiveness, right? You see in there. And then that's really before we get into the practice piece of it, which is like, okay, now we're actually trying to get large portions of populations to do it. We're looking at specific clinics implementing programs, etc. So your linear pipeline, which we talk about in the article this week a bit, is basic research to human research, then human research to practice and community-based work. And then we get into clinical practice and health policy, generally speaking. So applying it to sort of the whole population. Okay. And I like this too. Not ready for humans yet, still not ready for patients, but we are doing human research and then not ready for practice yet. So we're not sure how it's going to be implemented in sort of clinics or into public health policy. And then we finally get there in sort of this step 4 in this model. So this gives you a basic idea of translational research. And then Paul comes in, or Dr. Estabrooks comes in with his paper and sort of messes it up a little bit for us. So we're going to get into that messiness now. So he talks about dissemination and implementation research and how there needs to be more integration. So one of his main points is that he sort of starts his paper with is that we need to involve people who are downstream implementers of an intervention in the initial portions of the process. So come back to our linear model, right? We don't actually get to healthcare professionals until right here. And his sort of what he's suggesting a lot in his papers, we need more integration of these individuals in these 2 phases as well. Okay, which makes intuitive sense to most people, but it's not what has been done in the past. So, but we need to say, okay, if we develop this intervention, can it even be delivered in a healthcare setting? Is it practical? If I say, oh yeah, in clinical settings, so if I'm going to a hospital, I'm going to perform a VO2 max on somebody, for example. That is not a practical implementation strategy because you need so much infrastructure to support that kind of testing. Okay, so if I was going to include some type of cardiorespiratory fitness measurement in a clinical setting, I don't have the ability to do a typical VO2 max test. Now, I might be able to do some type of submaximal test, right? But that's where you need to see more of this integration of implementers, so the healthcare professionals, in that human research and in the basic research for developing these interventions. So that's sort of what this model here, and this is a figure from Dr. Estabrooks' paper. That's sort of what this figure is saying is, hey, look, like, so you see all these double-sided arrows. With basic research, we should be looking at feasibility and pilot trials already and how that's in working with basic research. So for example, right now, and this is people would totally disagree with me in saying this. So this is not scientific fact. It's just an opinion with genetic research, for example. If I determine that there is a genetic cause of a disease, but I have no ability to influence genetics, then why would I study that, right? So I'm not even ever going to get to this feasibility and pilot trials because I have no way to influence that basic research so we've decided that, in this figure I'm about to address, obesity is genetically determined, right? There's a genetic cause to obesity, right? Okay, but who is that helpful for? If I can't influence my genetics, is that a helpful finding? Can I do anything about it? And if not, then why are we doing that basic research in the first place? Now, in that regard, I wanted to come up here. This is a figure that we looked at in week 5. And it's looking at the different cause and effect relationships with obesity. So all of those little lines represented different causal factors in the pathway to developing obesity. And Paul or Dr. Estabrooks in his paper talks about over reductionism.
And that's the idea of like something like calories in, calories out model, where obesity comes down to how many calories you take in and how many calories you expend. And although, from a basic science perspective, that is absolutely correct, we know that it gets a lot more complicated than that with all of these different arrows running around in this obesity circle. Okay. So he talks about not overly reducing to basic science and really considering this overall picture. And I will say, maybe take a special look at the last section of his paper on, um, well, I forget what it's called, but it's sort of implementation in variety of populations. It's his cross-cutting section, which we'll get to in a minute. Um, it's really interesting how you could take one intervention and apply it to one setting. So I might apply an obesity intervention in Utah, for example. Well, if I tried to implement that same intervention in, let's say, Louisiana, I'm probably working with a really different population, really different context, really different climate. That intervention is not likely to be effective. So even though the basic underlying assumption behind the intervention is still valid, that calories in, calories out model, the way that I apply that model and that intervention in a Utah population needs to be really different than how I apply it in a Louisiana population in order for the interventions to be equally effective. Okay. So I need to be careful how I'm applying the principles and to whom I'm applying the principles that we've sort of discovered in this basic research model. Okay, coming to Dr. Estabrook's paper. So it's called An Overview of Dissemination and Implementation Science in Physical Activity and Health Promotion. First, I wanted to mention that the format's a little different in this paper than most papers we've read. So this is not, because it's an overview, it's not really a review. So it's not a systematic review. It's not a narrative review. It's not um, a randomized controlled trial, some of the things that we've looked at. It's not a prospective cohort. It's Dr. Estabrook's trying to sort of summarize some of the literature in dissemination and implementation science. So you can't really follow that model where we talk about sort of last paragraph of the introduction, first paragraph of the discussion, figures. That's not going to work as well here. Figures still work, so abstract still works, and figures still work. So when you're reading this paper, I would highly encourage you to go through the abstract, try to really understand it, Google words that you don't know. And then after that, I would probably go straight into my figures. Okay. And I'm gonna look at a couple of his figures here. We've already seen one. Um, Before I jump into that, though, dissemination and implementation. So, to disseminate means to spread information. So, we're talking about spreading information about physical activity and health promotion, and then implementation is putting that plan into effect. So, this is all a portion of translational science, but it's sort of what we would consider the latter end in that linear model. Okay. And so, we're not looking at basic research here, we're looking at really that implementation side of things. My first stop in this paper after the abstract and maybe the figures would be table one. So table one, he gives definitions to a lot of useful terms, and that will help you understand the paper. So I would not read the paper before reading table one at the very least, because you will understand the terminology used in the paper a lot more if you just have reviewed it before you start reading. Um, so he covers sort of the utility of theory-based D&I, so dissemination and implementation strategies to improve the re-aim outcomes. So re-aim is a theory or a framework that was developed, I think, in the 60s, and he mentions that in the paper. But re-aim stands for reach, effectiveness, adoption, implementation, and maintenance. So this is a way to evaluate interventions. So I want to evaluate the reach of an intervention, the effectiveness of an intervention, the adoption of an intervention, the implementation of an intervention, and the maintenance of an intervention. Okay, so think about all of these terms in for you, it will probably be most useful to think of it in a weight loss intervention strategy. So I have this weight loss and intervention strategy that I've come up with, and in this study, they use the Carillion Clinic Healthy Lifestyle Project, which was focused on sort of reducing overweight and obesity in their client population. So Think of those terms as a way to evaluate the effectiveness of an intervention. Some other terms that come up pretty regular or that are pretty important throughout the research paper are acceptability, appropriateness, feasibility, and penetration. And again, go to table 1 to sort of understand more about what those terms mean. Scaling interventions and reducing disparities. So again, the last section of his paper is really great. I think it's my favorite section of the paper. Scaling interventions just means something that I maybe applied to a small group. Let's say my intervention was targeted towards 40 individuals. I might not be able to make that apply to the general population. It might not be feasible. Okay, so scaling interventions is something really interesting that he talks about, as well as reducing disparities. So yes, we could talk about Utah versus Louisiana, but we could also talk about a white population versus a black population. There's a lot more research on a white population as opposed to a black population. And so I might not always be able to take this intervention developed with a white population in mind, test it on a white population, and then try to apply that to a black population. My outcomes are probably going to be different. Um, and that sort of would look at maybe mediators and moderators of this relationship. I've already talked about the developing strategies with the input of those responsible for implementation, so I'm going to skip over that. Broadly, the other thing that we've talked about this semester that could help you sort of understand some context for this paper is a per protocol versus an intention to treat analysis. So per protocol analysis means that everyone in a research study followed what they were supposed to do exactly. So if the intervention was 3 days a week of aerobic exercise for 30 minutes at a 4 MET value, that every individual who was randomized to that group performed that exact protocol. They never missed a day. They always were 30 minutes, right? That's a per protocol or per protocol analysis would require that anyway. Intention to treat, though, says, okay, now I've got these groups of people. If they were randomized to that exercise group, they're going to be analyzed as part of that exercise group, and even if they didn't do that exercise, okay? The research that Dr. Estabrooks does is more in that intention to treat analysis phase. So he's not doing any individual sort of research studies like this. I mean, he may be. I actually don't know that, but he's more focused on like this sort of zoomed out picture of are these interventions effective? But it is the same idea of trying to implement strategies that we've learned through basic research and intervention research rather than just saying, oh, well, this works, so everyone should do it. Okay, yeah, everyone should do it, but are they doing it? How do we get them to do it? How are we supporting them in doing it? That's more what he's examining here. Really briefly, I wanted to look at the 5 A's just because a lot of you will work with clients or patients in the future, and I think it's a really helpful framework to think about working with individuals. So when you're working with individuals on a personal basis, I want to sort of assess the situation generally, I want to advise individuals, and I want to agree on goals with individuals. So this is a collaborative process. I want to assist in barrier solution, and then I want to arrange some type of a follow-up with that individual. That's a really good model to think about in terms of working with people on health behavior change. Okay, last thing on this slide with his paper. So internal or explanatory versus external and pragmatic validity. Again, it comes back to this general idea that we've been talking about, but internal validity is talking about how did we establish that the causal relationship we're examining is not significantly influenced by other factors. So if I say, not probably a good thing to say, but if I say exercise, the association between exercise and weight loss, okay, I'm looking at that association. And in randomized controlled trials, that would be my most tightly controlled trial, so that would increase my internal validity the most. I can control for lots of little factors. So I could control for male versus female. I could control for age. I could control for diet potentially or caloric intake. So there's lots of things that I can control for that would help me say, no, it is in fact the exercise causing the weight loss. So we've talked about lots of different things, but last week in class we talked about mediators and moderators, right? So randomized controlled trials allow us to account for a mediator, right? Which in this case, or the example we talked about in class was um, ice cream trucks and murders, right? And the mediator variable there was temperature. Okay. And so there wasn't really a direct association between ice cream trucks and murders. It was just that when ice cream trucks are out, the temperature is higher and therefore murders are occurring. Moderator, so a good example for a moderator would be gender in the relationship between exercise and body composition. So the paper that we read last week examined how different types of exercise have different impacts on body composition, right? And one of the moderator variables was gender. So in that sub-analysis section of the paper, they examined gender and they did find certain differences between how exercises affected body composition on males versus on females. So that would be a moderator variable. So we still have the exercise weight loss, connection, but the magnitude of that connection is influenced by gender. Okay. Then you have things like confounders that could be influencing that internal validity piece. And age is a really common one. So if we looked at the association between physical activity and cardiovascular disease, for example, um, we would expect that as age goes up, cardiovascular disease increases. But I'm not interested in that. I don't want age to be the thing. I know that that's going to happen already. I want to see if physical activity and cardiovascular disease are related. So I need to account for age in that process. So um, moderators and confounders are really similar. Moderators are variables I might be really interested in, like sex. Age, I already sort of feel like I understand the effect, so I would call that more of a confounder. I'm not as interested in it, but I know I need to control for it because I already know it's going to affect that physical activity CVD relationship. Okay. Um, then the paper also discusses looking at determinants in terms of internal validity. So a determinant, right? Common one would be like smoking and lung cancer. Smoking is the determinant in this case. It's the primary variable that I'm interested in, or potentially the primary mechanism that I'm interested in examining. Okay, that's internal validity. So all of those are the things that we would look at in a really tightly controlled study. Then we have external validity or pragmatic validity. And here we're interested in the extent to which the results can be generalized to other contexts. Okay, so this is sort of coming back to my example earlier, right? That Utah intervention versus the Louisiana intervention. I might have developed this great Utah intervention. It's totally effective, but then I try to apply that in Louisiana and it totally fails and it's not effective. Okay, so that would indicate that I have poor external validity. I had great internal validity, but that's not generalizable to other populations. Okay. Or I might have seen an effect of resistance training on males, but now I don't see that in females. So I had good internal validity for the male section, but when I try to apply that to females, the external validity is not there. Okay. And one of the things that we're really looking at in terms of the studies that we're doing, and it's whether it's internally valid or not, would be representative populations. So if I just study males, that's not a representative population. If I just study white individuals, not a representative population. Okay, so I want to study as broad of a population as I can, or at the very least, I want to say, okay, my findings only apply to a white male population if I only studied white males, which by the way is really tough to do now. You have to get that through like an ethics review board, and most review boards will be like, wait, what's your justification for only studying white males? Um, and you have to try to justify that as a researcher, which is tough to do. So, and then also looking at with external validity, looking at highly controlled lab settings. So I might develop this intervention, but I have, 10 researchers working on this study. I've got personal trainers, I've got nurses, I've got healthcare professionals all invested in this trial, right? But when I go out and try to apply that in the real world where I don't have all this support, the findings might not apply, or that might not be a practical intervention. Okay, so that would again contribute to low external validity. And then I did say I was going to come back to this concept cross-cutting that Dr. Estabrooks talks about in his paper. Cross-cutting is just referring to the representativeness of the population and how robust those results are across different populations. So making sure that that's like sort of a consistent finding across variety of populations. It's a term I hadn't heard before, so I wanted to review it here. Okay, I'm going to be really quick on these last two slides. This is a great figure from Dr. Estabrooks' study. So here he's examining, so this was from the Carillion Clinic Healthy Lifestyle Project, and looking at the RE-AIM outcomes. So again, RE-AIM, we've got reach, effectiveness, adoption, implementation, and delivery. And they compared their full intervention to just providing continuing medical education to the healthcare professionals. And what they found was that they saw increased patient reach for their intervention. They saw increased effectiveness of, or so the effectiveness they operationalized as the proportion of individuals achieving 5% weight loss. So more people were achieving 5% weight loss or more. Nurses were adopting these intervention strategies more regularly. Implementation fidelity was similar, interestingly. So fidelity means how closely, and you can look at this in table 1, but how closely was I following the intervention protocols? And probably no difference here, but maybe even a little bit higher in the just the continuing medical education. So that makes sense, right? When I start to apply something more broadly, it tends to get a little bit messier. It gets harder to apply across the board universally to everyone. Okay. And then we saw increased maintenance of delivery as well in the full intervention group. So more sustainability would would be sort of my interpretation there. So anyway, really, this looks to me like, oh, okay, this was a good intervention then. The way that they were implementing this, the strategies that they used were effective. And then the strategies that those were are sort of covered in this other figure, which is a little bit messier, but I would encourage you to take some time and really try to understand what's happening here. So on the left side, we've got research, right side, we've got practice. And this entire paper really is about trying to integrate those two things. So you see research, practice, and then those integration trials. So run through this figure, read it, see if you can understand it. Again, try to think about this all in terms of a weight loss intervention. I think that will help give you some context for what does this all mean. Oh, and the last thing I wanted to mention was with the trial they did. So they provided continuing medical education, and then they did more training in the full intervention. Notice that the control wasn't not providing anything. So two reasons that this might be the case. One is if you're a researcher and you're trying to get a clinic, a healthcare clinic to allow you to come in and measure patient outcomes, often you need to provide them something, an incentive to allow you to do that. If you just come in and say, yeah, I just need access to patient outcomes and we're going to measure them for the next 6 months, that gives the clinic more work to do. And if you haven't given them any incentive, they're probably not going to do that. So that's one reason why I might want to provide a something to a clinic to incentivize them to participate in the study. But the other reason is if we have enough research to back up that our intervention is effective, it's on some level unethical for us not to provide that information to the clinic that we're studying. So you can get into some really messy issues, but there was, I forget the name of it. I think it was the Tuskegee experiment. That ran from like I'm gonna miss these dates, but like 1930s, I want to say, up to like maybe 1970s. And they were studying syphilis. And during that time, we discovered that syphilis could be easily treated. And so uh, sorry, I got a little distracted. So we found out that syphilis could be easily treated, but the patients in that study were not told that syphilis could be treated. They were just continued to be studied. So that's unethical. So similarly, in this situation, if we have an effective intervention, and we know that it's effective, but we don't give that information to like the medical professionals, that would be considered unethical. So that's why we might see this continuing medical education being sort of my control group. Okay. Okay. Take a look at this figure, try to puzzle through it. Good luck with the research article. I think it's a great article. I hope I provided you some context to help you understand it. And I will see you all in class on Thursday.